Well, good morning, or maybe it is afternoon where you are at. Thank you for joining us today for our webinar on a discussion of the 2023 ACC, AHA, ACCP, HRS guideline for the diagnosis and management of atrial fibrillation. We're thrilled that you've joined us, and we have an action-packed hour planned. So put on your seatbelt, buckle up. Hopefully you've got a cup of coffee. Next slide, Arthur. So today joining us, we have the great Arthur Allen. Arthur is a pharmacist. He is the anticoagulation program manager at the VA Salt Lake City Healthcare System. He's going to be presenting our slide deck today and moderating as well. Myself, I'm Andrea Van Beek. I'm a nurse practitioner in the Anticoagulation and Thrombosis Service at Visalia Medical Clinic, Adventist Health Physicians Network in Central California. Our panelists today, drum roll, we have Anastasia Armbruster. She's a pharmacist and professor of pharmacy practice at St. Louis College of Pharmacy at UHSP. And we have Dr. Renato Lopes. He's a professor of medicine in the Division of Cardiology at Duke University Health System. And now I'm going to turn it over to Arthur and take it away.
All right, thank you, Andrea, and thank you all for being here. This is going to be a jam-packed session. There's a lot to talk about in these guidelines, and there's a lot of slides. I've had about a dozen espressos to go at the pace I need to go to get through everything. First of all, anytime you talk about guidelines, you want to be aware of the grades of recommendation. So this is the table used, and as a reminder, the grade of recommendation can be a class 1, very strong recommendation that works all the way down to actually recommendations where there's harm. So you have these strong kind of harm recommendations where the risk is thought to outweigh the benefit. You also have level of evidence. So with level A being a very strong, multiple RCTs and so on, to get the evidence, working your way down to more kind of expert opinion. So keep that in mind as we go through these guidelines. And although there's a lot in the AFib guidelines that covers it from top to bottom, based on the focus of our organization and based on the interest of our audience, we really want to focus on prevention of thromboembolism, what we can pull out from that, and also because we only have an hour and not a half a day to talk about this. So we're going to really try to focus on prevention of thromboembolism. First of all, it's important to remember that we work for the patients. They are the ultimate decision makers in their care, and shared decision making is a favored approach in the guidelines. The guidelines also incorporate a table that have some links to some really neat shared decision-making tools that if you haven't checked these out, I would recommend you do so. Also not listed here, perhaps because of concern for nepotism, is ACC themselves. They actually have a great risk-benefit tool to use to help guide through these discussions. Risk stratification scheme. So for a long time, you've seen guidelines. We go historically talking about CHADS 2 score. If you go more in the last decade or so, CHADS VAS score. The guidelines really take a turn a little bit in this rendition and talk about the annual risk of thromboembolic events, which is really what those two tools are getting at. But there are other things that can be used to calculate annualized risk, as well as other contributors to risk of stroke to help to allow us to be kind of more individualized to individual patients. So you'll see a focus more here on really annualized risk, with CHADS VAS being an example of how to calculate that, and you'll see it as we go through. There's also a recommendation to evaluate for factors that specifically indicate a higher risk of bleeding for the purpose of identifying and possibly intervening on those things so that we can reduce the risk of bleeding in patients on anticoagulants. There's some language about an intermediate annual risk of stroke. So we have these patients that fall kind of in this intermediate risk. We'll see it a little bit later when we talk about anticoagulation therapy. But this statement really is more about those who remain uncertain about the benefits of anticoagulation therapy. They can benefit from consideration of factors that might modify their risk of stroke to help inform that decision. So the example given here is things like atrial fibrillation burden, but there's a table that refers to other things that may contribute to annualized risk. And then really bleeding, again, going back to the bleeding risk scores, we see this first no benefit, that risk scores are not used to weigh, should we use an anticoagulant or not? Well, the risk of bleeding is 4% per year. The risk of stroke is, 4% per year. Those cancel each other out. It's never what they were designed to do. And again, the reiteration of bleeding risk score should be used to isolate things that can be modified and to reduce those modifiable risk factors. So going back to the risk scores and those things that can tie to stroke risk, you see here again, going back historically, CHADS score, the CHADS VAS score, but there are some other in the guidelines. There's this table that shows these other validated risk estimation tools that could be put into play. In addition, there's this table 11 that talks about additional risk factors that could be contributory to stroke risk, things like burden, cardiomyopathy, enlarged left atrial volume. Any of these things may impact an individual patient and could be considered in these discussions and decisions. So there's also this guideline here about balancing the risk and the benefit. This is where we start seeing that those with an annualized risk of thromboembolic events greater than 2%, really regardless of whether the atrial fibrillation pattern is paroxysmal, persistent, long-standing, permanent, they all get treated the same. And when they have that CHADS-VAS score that high. And then a reminder to us to reevaluate the considerations and the risk benefit of oral anticoagulation therapy or other stroke prevention modalities at periodic intervals. This isn't a set it and forget it scenario. Now getting into the meat of the antithrombotic recommendations, a lot of this will look very familiar in patients who have an estimated atrial fibrillation and an estimated thromboembolic risk of 2% or greater. And that's again that CHADS VAS score of 2 or more in men, 3 or more in women. But again, other ways to calculate that. Anticoagulation is recommended. That's a 1A recommendation. In patients with AFib who do not have a history of moderate to severe rheumatic mitral stenosis or a mechanical valve, DOACs are recommended over warfarin. So we're going to come back to that specific language a little bit later in the talk. In patients with AFib and an estimated annualized thromboembolic risk of greater than 1%, but less than 2. So this is that they haven't met the 2% threshold, but they're greater than 1. Anticoagulation is reasonable. This is not new. It goes back to this CHADS-VAS, the idea of a CHADS-VAS score of 1 in men or 2 in women, or some of those other scores can help you get there as well. There's a couple of good recommendations here about antiplatelet therapy. So if a patient, based on those criteria, is a candidate for anticoagulation therapy, it is not recommended to use aspirin either alone or in combination with Plavix as an alternative for risk of harm. And in patients who have atrial fibrillation, but they don't rise to the risk level of stroke, aspirin monotherapy for prevention is actually not recommended. No benefit. So we need to really get aspirin antiplatelet therapy for AFib out of our mind. We've been seeing this strengthening recommendations through different renditions of guidelines. This is nicely laid out in this algorithmic form, simplified a bit that we see here on the right of how to treat, both with whether or not we should anticoagulate and choice of agent. I would also highlight that the Centers of Excellence team is putting out a special edition of the Rapid Recap. I'll show you that in a moment. And as part of that, Candace Bryant was kind enough to let me use a table that she put together that looked at annualized stroke risk using CHADS-VAS, which we're accustomed to, but also showing what some of those other validated tools might look like, where therapy would be recommended versus reasonable at moderate risk level. So in considering, how do we manage anticoagulants? There's language about patients receiving DOAC should have optimal management of drug interactions as recommended. For warfarin, typical recommendation INR between 2 and 3 is recommended, as well as optimal management of drug-drug interactions, vitamin K intake, and so on, routine INR monitoring, just doing a good job with warfarin, which is what this organization was founded on. And then this risk of harm, non-evidence-based doses of DOAC should be avoided to minimize risk of preventable thromboembolism or major bleeding to improve survival. So the guidelines taking a pretty strong stance on, we don't just go, the patient looks frail and give them a lower dose. We use evidence-based doses. So I'd like to bring in real quickly, Anastasia Armbruster was one of the authors of these guidelines. I thought I'd bring her in and ask her, I mentioned what I thought was significant, which needed to be presented, but what do you see, Anastasia, that you would highlight or that you think maybe represents a significant difference here?
Yeah, and I think you did a great job highlighting especially the areas around prevention of thromboembolism. I do love the new AF stages. I will make a bid for those to be a big change. I think really an emphasis on, there's a continuum of atrial fibrillation. What can we do to reduce the patient's risk, reduce their burden, and really that goes into prevention of thromboembolism as well. As authors, we talked a lot about CHADS2-VASc, which has always had such a prominent, place since it came out before, CHADS2 and then CHADS2-VASc in the guidelines. I think it's really important to now start to understand there are risk factors like obesity and renal dysfunction that don't fit into that risk score. And as we see patients, we know those, have a high prevalence. So really starting to think outside the box in a shared decision manner to discuss their risks with patients and realize that maybe CHADS2-VASc isn't a one size fits all. I'm glad that you stated the guidelines took a strong stance on these alternate dosing. There were 3 pharmacist authors on this guideline, as well as collaboration with American College of Clinical Pharmacy. So I think that comes through in some of the monitoring recommendations as well, which is really the first time we've seen something like that in the guidelines, but really a focus on what is safe and effective dosing as well.
Excellent. Thank you so much for that time. And I knew I should have left that AFib stages slide in. I had a slide in that showed that nice graphic. I should have kept it in. I cut it for time, but I would encourage the audience to go back and look at the early parts of the guidelines and really talk more about the disease state itself. And I agree with you. There was kind of this shift in thinking about atrial fibrillation almost as a spectrum, starting at risk of,
yes,
all the way through atrial fibrillation. So thank you for that.
And
Renato,
can I just add one comment, because I think that's an important change in this guideline, which is in the DOAC era, we got then the threshold of that magic number of 1% risk per year of stroke as the kind of magic number where anything above would deserve anticoagulation. And then, of course, we have almost a decade and a half of DOACs now, 15 years, and we learn more about risk of stroke and treating other comorbidities and things like that. And I think the guidelines now change a little bit this magic number of 1%. So now 2% or greater is really where we have a class 1 recommendation, 1A to treat. And then between 1 and 2, probably we still get the benefit, but now it's a 2A recommendation. So I think that's an important update based on the most current era of the real stroke rate, because also we got better in treating patients overall with other medications that have implications also for the stroke risk. So I think that changing that 1% number, which was pretty much magic, and now to more like a 2%, really as a new threshold where there is no doubt we should treat. And then between 1 and 2, likely we're going to benefit from that, but the level of evidence is a little bit less robust.
Excellent. Thank you, Renato. Yeah, and I would just like to, I often try to come back to, for us to think that in an individual patient, we can actually, really know their risk of stroke, I think is a bit pompous. I think that we need to understand how validated risk scores are in fact validated. And then remember something I learned many, many years ago: diseases don't read textbooks. And so understand that individual patient risk is individual patient risk, and we do the best that we can to try to estimate it, but we're not soothsayers. So at any rate, thank you for that. We'll get going back through some more of the slides here. So I really wanted to also take a jump and talk about subclinical AFib, which was highlighted in this guideline, but more recently in a couple of important papers. So if you look on the left, you see the guideline document table that talks about subclinical atrial fibrillation, and they refer to atrial high rate episodes lasting greater than 24 hours. If they then have a CHADS-VASc score of 2 or greater, as we've kind of talked about, it's reasonable to initiate oral anticoagulation therapy using a shared decision framework. If they have atrial fibrillation or high rate episodes between 5 minutes and 24 hours with a CHADS-VASc of greater than or equal to 3 or equivalent stroke risk, and it may be reasonable. This would be kind of like that moderate risk patient that we talked about earlier. And then no benefit if they have really very brief episodes lasting less than 5 minutes. and without any other indication for oral anticoagulation therapy, and the therapy should probably be avoided. Then on the right, we see this graphic that appeared in the document, but we see that it has different timelines. We see that the different cut points are 6 minutes to 5.5 hours. High atrial rates greater than 5.5 hours, or those greater than 24 hours. I'd like to point out this actually, it did appear in the guideline, but it was actually copied from an AHA scientific statement from 2019. In that graphic, it actually points out that Artesia and NOAA will provide some evidence to this, but I wanted to highlight the difference what's presented in the guideline between the recommendations and this figure. And then I also wanted to take a little detour, since we have Renato Lopes with us, who is an author on Artesia and author on a meta-analysis that followed. So Artesia was a paper that a lot of us were waiting on to hopefully inform kind of at which point is anticoagulation therapy justified in subclinical AFib. So this trial was a randomized double-blind, double-dummy trial with at least one episode of device-detected subclinical AFib lasting greater than 6 minutes to less than 24 hours, and over 4,000 patients who met those criteria and had a CHA2DS2-VASc of at least 3 or higher from 16 different countries were included in the trial. And apixaban was compared to aspirin. We've already talked about aspirin, about its role or lack thereof in atrial fibrillation, but was compared to aspirin in this trial. And if the AFib lasted greater than 24 hours at any point throughout the trial, they were essentially unblinded, if you will, and they had study drug discontinued and were given open label anticoagulation therapy, but continued to follow, which I think is very important in this trial. Primary outcomes were composite of stroke and systemic embolism, and the safety outcome was ISTH major bleed. So high level, you see on the right, the Kaplan-Meier curve, essentially compared to aspirin, apixaban resulted in a 37% reduction in stroke and systemic embolism, giving a number needed to treat of about 172. But it's important to note, AFib strokes are different. We need to remember this. AFib strokes are different. And to me, not surprisingly, 49% decline in disabling or fatal strokes because atrial fibrillation strokes are different. And 45% of strokes in the aspirin arm resulted in death or long-term disability. This came, though, at a cost of an 80% increase in major bleeding, so the number needed to harm of about 130. But it's important to also note that apixaban did not result in substantially higher rates of transfusion, fatal bleeding, hemorrhagic stroke, or intracranial hemorrhage compared to aspirin. And about 90% of all apixaban-related bleeds were managed with non-procedural measures only. So things that make Arthur scratch his bald head on this paper. If you look in the baseline characteristics, patients were put into these buckets at the start of the trial based on their burden, if you will. I'm gonna use the term burden. I don't know if that's actually accurate. I'm gonna use that term. But for the final results, all of those patients were kind of lumped together, if you will. There were no outcomes by those buckets. Did some patients that started the trial with more burden, for example, have a different level of benefit? Since I have Renato here, I'm going to call for a post hoc analysis. I would love to see that. Nearly a quarter of patients had trial med discontinued because they went from meeting the criteria for this study, having less than 24 hours of subclinical AFib, to either having more than 24 hours or clinical AFib. And the median time to discontinuation was about 18.3 hours, but there's a wide range, likely, in my opinion, I would assume based on how much AFib they had at the start of the trial. And there were also a third of the patients in each group had trial med discontinued for other reasons that I didn't see well explained. So that was curious to me. There's actually a lot of it from this trial that I found interesting. I do think the rate at which they converted to subclinical AFib lasting more than 24 hours or clinical AFib could really be meaningful for kind of follow-up and monitoring. Now, I'm not going to present the NOAA trial, but I will show the meta-analysis. Again, Renato was involved in this, that closely followed Artesia, that took the results of NOAA AFNet-6, in which case, by the way, they compared the placebo, not aspirin, and Artesia, which compared apixaban to aspirin. And they put those together. And again, the moral of the story is you put them on a DOAC, they have less stroke, they have more bleeding, but they don't have more fatal bleeding. So, Renato, what's the skinny? Fill us in, help us understand what to do with this information.
Thanks, Arthur. Great presentation, great overview. As you pointed out, before the Artesia and NOAA, we didn't have really systematic or studies that were systematically done. And we have some studies showing that maybe 5.5 hours is what increase your risk of stroke for patients with subclinical AF. There are some other studies showing that maybe above 6 minutes or maybe above 2 hours, or so the data was all over the world, all over the place, and we didn't have really a robust, large enough of a trial to give us the answer. And that's why when we look at ASSERT, which was the largest before Artesia and the NOAA trial, the ASSERT trial really showed that the risk seems to increase above 6 minutes, but between 6 minutes and 24 hours, based on ASSERT, the risk of stroke for similar CHA2DS2-VASc score or CHA2DS2 score was about half in patients with subclinical AF compared to clinical AF. And that was really the population that then we wanted to study, because above 24 hours, ASSERT suggested that the risk of stroke was similar to clinical AF. So we were not interested in the more than 24 hours. And that's why in the trial, we censor patients who develop clinical AFib or more than 24 hours of AFib, because in our view, this population deserved to be treated, and therefore we were not interested in study. And that was the rationale for us picking up between 6 minutes and 24 hours as the time window. I understand it's a long window, but that was really the question. You know, we didn't know what to do with those patients. And importantly, the meta-analysis that we did, because some people might say, well, the NOAA trial is neutral, or it was negative, or was stopped for futility, and the Artesia is a positive trial, so they are very different. And I think the main message here for the audience is that NOAA and Artesia are completely aligned in the results. If you look at the point estimates, the NOAA trial was underpowered. It was terminated prematurely. They had a composite endpoint that also included mortality, cardiovascular mortality, in the primary efficacy endpoint, which we typically don't do for AFib, because all-cause cardiovascular mortality is not something that we expect to be reduced by oral anticoagulation. But when you try to adjust and compare and lump whatever apples to apples and orange to orange, you can appreciate that actually the results are extremely aligned, and basically showing that, yes, if we treat these patients, we're going to have a reduction in strokes. And more importantly, not just any stroke, but bad strokes will be reduced when we anticoagulate these patients. There is a cost because we are comparing an anticoagulant versus aspirin in a higher risk patients, CHA2DS2-VASc of 4 or 5, plus in a population that is much older than the classic AFib trials. Here the population was 77, 78, so much older. So yes, we'll see more bleeding, but there is clearly a benefit in the reduction in stroke. And that's why when we want to compare stroke, and you present the author, stroke reduction versus increasing bleeding, first of all, we need to think about also using the same population, because the stroke reduction is using ITT, and the bleeding results is using on treatment. So if you really want to compare rates of increase and decrease, it's better to look at the same population, the on treatment for both or the ITT for both. And when we do this, we can see that basically they are very similar. The reduction in stroke is very similar to the increase in bleeding, although the severity of the events is not the same. And that's very important. One stroke does not equal one bleed, because we reduce 50% or about 50% of bad strokes. And yes, we did cause more bleeding, but none of those bleeds were fatal, intracranial, or that require major interventions. There was no differences in those bad bleeds between apixaban and aspirin. So again, I think the key here, Arthur, is that I think we have now robust data with the two trials together, almost 7,000 patients, to show that there is a benefit clearly in reducing bad strokes at a cost of increasing bleeds. They are not necessarily bad bleeds, but they are bleeds that we should be taking care of and should pay attention. So now the subsequent analysis that we are looking at and we're going to present during this year is going to be trying to find who are the patients who most benefit from this treatment. Who are the patients without a doubt that the risk of stroke is above 2%, above 1.5%, and therefore the benefit of stroke outweighs the risk of bleeding. We're going to look at duration of AFib. Does it matter if it's 1 hour versus 17 hours? Does that matter? We're going to be looking at. Does that matter? We're going to look at also burden of AFib, because we look at the longest episode of AFib. But is a 3 episode of 20 minutes the same as 1 hour duration of AFib? Single 1 hour duration? So we don't know. So the beauty here is that the database is so robust and we collected so many details around AFib and all the atriograms and everything else that we're going to be able to actually tease those things out in terms of burden of AFib, duration of AFib, CHA2DS2-VASc score, and other maybe risk factors or even other scores to predict stroke in this population, which is different in terms of the clinical AF.
Thank you, Renato. I knew that you guys weren't done with the data. I knew that there was going to be more to come. I'm excited to see it. And to your point, these trials, one of the problems with AFib trials has, in my opinion, always been, how do you get it net benefit? Because you can't just compare, numbers versus numbers. And I think that it's easy to fall down that rabbit hole. So anyway, thank you so much for that excellent explanation, and excited to see what's to come on that. Thank you. All right, let me mention just real quickly, jump into left atrial appendage here. As you likely know, at least 90% of clot that originates in the heart and can be sent out for stroke or systemic embolism comes from the left atrial appendage. So it's of course of interest. So we have guidance here about left atrial appendage occlusion. The idea of using left atrial appendage occlusion, such as Watchman device, for example, or the newer amulet device, is not new. As far as considering it for patients with a contraindication to long-term use. The second recommendation listed here were in those patients who are at high risk of bleeding, not perhaps those who have already bled, but those are at high risk of bleeding. That left atrial appendage occlusion may be a reasonable alternative to oral anticoagulation therapy. I believe this might be a newer recommendation, still to be. And the other thing that I liked here was table 14, which really oftentimes is the anticoagulant contraindicated. Should we retrial it? It often feels very subjective. And so the table here tries to put a little bit of objectivity to what should we really think about with regard to long-term anticoagulation contraindications versus those in who it's still reasonable to try anticoagulation therapy. The other thing I thought I would mention in this section is surgical left atrial appendage exclusion or excision. You may hear it called ligation. It's very common, as we know, for patients who go to cardiac surgery to have left atrial appendage exclusion, one way, whether it's through atria clipping or tying off or excision, whatever. And that is a recommended practice, but it's recommended in addition to anticoagulation therapy when the anticoagulation therapy is indicated. The third recommendation here is that in those patients who have AFib undergoing cardiac surgery with CHA2DS2-VASc score greater than 2 or equivalent stroke risk, the benefit of surgical left atrial appendage exclusion in the absence of continuing anticoagulation therapy is unknown. So it's really important to know that left atrial appendage occlusion and left atrial appendage excision, or basically approaching it from outside of the heart, those are two different things. They're not the same. In fact, I once met in the early days of Watchman, when the device was harder to place and larger, I once met an electrophysiologist who had successfully placed a Watchman device in a patient who had undergone left atrial appendage exclusion surgically. So it is not the same. It is, and now this isn't talking about brief episodes of atrial fibrillation for cardiac surgery. There's a whole section in the guidelines about that. This is specifically if they have an ongoing atrial fibrillation issue. The fact that they have had this done surgically doesn't mean you don't anticoagulate them. All right, OSC-related bleeding. There's a nice table in the guidelines that talk about, they kind of walk through what do we do in the setting of bleeding. And as you can see on left and the right, you don't always have to reverse or replace factor. For minor bleeding, non-life-threatening bleeding, supportive measures, plus or minus holding the anticoagulant is often all that you need. But in the setting where we do have life-threatening bleeding or concern for such, concern, if you have to stop it for surgery, you have to have major bleeding, that kind of thing, then of course the reversal or replacement strategy is dependent on the agent in use, with 4-factor PCC and plus vitamin K getting a 1A recommendation for warfarin. Idarucizumab, a 1B recommendation for dabigatran, but if you don't have access to it, activated PCC as the backup to that. And then for the factor 10A inhibitors, andexanet alpha, with a slightly higher, greater recommendation for Andexa for apixaban and rivaroxaban than we see for either Andexa for edoxaban, which is off-label use, or 4-factor PCC for reversal of any 10A agents, which again is off-label use as well. The other nice things I saw in the guidelines were some guidance on resumption of anticoagulation. Again, that theme of trying to get away from this being a completely subjective issue to putting a little bit of objective data to it, I think was a great addition. Resumption of oral anticoagulation therapy may be considered after correction of reversible causes of bleeding in the setting of GI bleeding, again, using shared decision making. For ICH, he actually tried to put a number on it, which I thought was nice. So, and if you have a condition where the risk of thromboembolic events is greater than, it's estimated to be greater than 5% per year, such as rheumatic heart disease or mechanical valves, but I would add atrial fibrillation patients with a CHA2DS2-VASc score greater than 5 would meet that criteria. Then early 1 to 2 weeks of resumption of OAC after ICH is reasonable. It's more reasonable to delay following ICH if they don't meet those criteria, perhaps 4 to 8 weeks. Again, at least they're putting a number on it, which we don't always see. And then in conditions associated with a high risk of recurrent ICH, the example given here is cerebral amyloid angiopathy, anticoagulation sparing strategies such as left atrial appendage occlusion may be considered. So really nice addition. The other thing that they added was this nice table that really looks at factors associated with high thromboembolic risk, as well as factors associated with a high risk of recurrent ischemic or intracranial hemorrhage. And remember, not all head bleeds are the same. They really do have different degrees of risk of recurrence, potential morbidity, mortality associated with the different types of bleeds. A really nice table here to try to explain and try to be a bit objective about it. I also want to jump into periprocedural management here. There are some guidelines. We have this nice table that walks through how patients might be considered for periprocedural management. They actually have this spinoff on the right here specific to pacemakers or ICD implant. In some cases, we may consider proceeding with uninterrupted therapy. In other situations, we may consider brief interruption of therapy. There is a concern for pocket hematoma. I think since the bruise control and bruise control true trials came out, I think kind of taking a one-size-fits-all and not reversing has kind of been what we've seen in practice, but these guidelines kind of bring it back to you may not always have to accept that risk. And then walking through when you can't do uninterrupted anticoagulation therapy, how to think about those patients. We see some temporary cessation with warfarin, some temporary cessation with DOACs. We see in the yellow on the left here, there are considerations for delaying resumption and higher risk bleeding for immediate acting DOACs. But here's what I really want to highlight. If you've known me or heard me talk about this topic at all, you know that this is a pet peeve of mine. And the fact that the guidelines just basically said don't bridge AFib patients, with the exception of these mechanical valves or perhaps recent stroke or TIA, which we could even argue about. I just think that this is a step absolutely in the right direction. Kudos to the authors of this trial for being willing to be the first to really come out and not nitpick over higher CHA2DS2-VASc patients. And as I think back about this topic, I swear it might have been like 8 years ago. I don't remember. I swear that I've seen somebody say this before, that perhaps bridging is more harmful than helpful, but I don't know. It'll come to me. I'll think about it a little bit longer. There's also a table here about interruption times for specific agents, and you'll see it looks really a lot like what you might find in either the PAUSE study for DOACs or some of the subsequent periprocedural guidelines that followed PAUSE, which really regiment and simplify how to interrupt, specifically DOACs, I would say. So I thought I would maybe bring it back and talk to maybe Anastasia first as an author of the guidelines. Can you talk about the paraprocedural recommendations and any thoughts that you have on the changes and on the conversations that occurred in the writing of these guidelines, specifically the idea of bridging AFib patients?
Yeah, I think, and AHA and ACC always take a strong approach to go back to the data. And I think when authors reviewed that data, that really resulted in the recommendations that everyone is reading. I think AFib is difficult because there's a lot of things to talk about. It's one of our longest guidelines. So, even including periprocedural management, there are other documents that speak to that space. But I think, as a committee, we felt like bringing all of that together with the most updated data was most important for patient care.
Excellent job on that. I just really appreciate, I think that it's been a stepwise approach across a number of guidelines to really remove, if you will, a consideration for bridging based strictly on AFib and CHA2DS2-VASc score. Renato, what are your thoughts, just real briefly, on bridging AFib patients and on this kind of simpler approach that this guideline takes?
Yeah, no, I think that was a great also step forward in the right direction, Arthur, because not just the bridge trial, which was really important, but other data that came showing the same direction of results, the same trend. And sometimes we just tend to apply things we learned 20, 30 years ago in medical school or in school or nursing school. And then basically we don't realize that sometimes we might be causing more harm than benefit. And when you look at also the totality of data that we have on AFib on peri-procedure interruptions, is also basically very reassuring that the risk of thromboembolic events in the first 30 days is very, very, very low. And actually, if you start combining anticoagulants with long half-lives, etc., you are more likely to really have more bleeds than any potential benefit. So I think the DOACs helped a lot in the understanding of this issue. And of course, studies like the bridge trial were really instrumental for us to really demonstrate that that's the case, except in specific situations where there will be exceptions in not the default and not the rules.
Thank you so much. Yeah, I think that bridging, when you draw it out on paper and you explain why we do it, it makes a whole lot of sense. And I think that people have really held on to, but it really makes a lot of sense rather than the data that says it doesn't prevent events and it causes harm. Oftentimes the argument for the trials have been, well, but they were really underpowered to show a difference in thromboembolic events. I'm like, yeah, because they like almost never happen. But guess what? They were plenty powered to show increase in major bleeding. So again, thank you so much.
And the other thing, Arthur, that I just think is important for this audience is that I've seen people say, okay, that's the case that is not worth it doing for warfarin, but if you're a NOAC, then it's probably okay, which doesn't make any sense. Think about if you have a DOAC with a very short half-life, almost the same as heparin, there is no sense in bridging because you're already using a drug. Unlike warfarin that has a very long 5 days half-life, here we already have a drug that has 8 to 12 hours of half-life. Therefore, there is no clinical sense in bridging patients on a NOAC. I'm just bringing that up because once in a while I hear people saying those crazy things, and it's just if we stop to think about it, we realize that there is no sense. There doesn't make no sense in bridging patients with DOACs.
Absolutely. And I'll tell you what, if you keep talking about drug half-lives, we're going to have to give you an honorary PharmD there, my friend. So, thank you. Excellent conversation. All right, so let's jump real quick to some special populations in the guidelines. There's a little bit of language about special populations. So certainly we have some guidance, and this isn't terribly new in the CAD population of how best to manage patients in the when they do have a strong indication for an antiplatelet therapy for a period of time, what to do with those patients. And again, Renato is involved in one of the most important studies that really lead to the guidelines of DOACs. If you have a patient who has AFib and they're undergoing CAD, or with CAD, excuse me, undergoing PCI, DOACs are preferred over vitamin K antagonists. Why? Because the best data to define what to do came from the DOAC trials, and at baseline, you're starting with a significant risk reduction, specifically head bleeds and major bleeding compared to warfarin. They also recommend early discontinuation of aspirin and continuation of dual antiplatelet therapy with OAC and a P2Y12 inhibitor over triple therapy. Again, DOAC trials taught us that. Renato was involved in the apixaban trial that showed us that. Chronic coronary disease, you may have seen this in previous guidelines, referred to as stable coronary disease. And I kind of like the language change, because when you say stable coronary disease, you have to think about, yeah, but this patient has multiple stents, or this patient has whatever. I like the idea of saying, let's call it chronic coronary disease. So those that are beyond a year of revascularization or of an event, like an ACS event, for example, anticoagulation monotherapy is recommended. There isn't really a need in most patients for concomitant antiplatelet therapy. Kind of period. This is new. This is not new for CAD. We've known this for a while. All of this is the one place where guidelines historically, before the DOAC trials and PCI trials, where the guidelines didn't even agree with each other. Guess what they agreed on? They agreed on. There's also a statement about PAD, which is a nice addition, because I think that we've known for a long time the right move in the CAD in the coronary vasculature. But when we get outside of the coronary vasculature, I think some of us have a hard time, like, gosh, is there a place for concomitant aspirin? So to have a PAD statement, again, that monotherapy is a reasonable approach, is a nice statement to have. There's some guidance still down to special populations here. Chronic kidney disease, those patients with stage 3 kidney disease, continuing evidence-based doses of direct thrombin inhibitors. Stage 4, warfarin or labeled doses of DOACs is reasonable. End-stage renal disease or dialysis, it might be reasonable to prescribe warfarin or an evidence-based dose of apixaban. Again, this focus on use the doses that were studied, use what we know. And again, the language here in the end stage is also not terribly new. It might be reasonable too. We don't actually know definitively the net benefit or net harm that may be caused from anticoagulation therapy, certainly warfarin, in dialysis patients. But if you're going to anticoagulate them, then using apixaban is a reasonable option. There's a statement here. There's been a lot of talk over the years with DOACs about obesity. I think we're finally putting that to bed a bit. Even in patients with a BMI over 40, DOACs are reasonable to choose over warfarin to a recommendation. And then patients who have undergone bariatric surgery, warfarin may be reasonable to choose over DOACs to be recommendation, but I would remind you that in the venous thrombosis literature, we also have some guidance stating that if they're more than a month out from their procedure, it's probably reasonable to use a DOAC as well. And then valvular heart disease, there is a separate section. You saw me earlier mention a statement that was in the guidelines that I'll show you in a moment. Here in the valvular heart disease section, rheumatic mitral stenosis or mitral stenosis of moderate or greater severity. So it lists both rheumatic and non-rheumatic, that warfarin is recommended over DOACs independent of CHA2DS2-VASc. And then valvular disease other than moderate or greater mitral stenosis or mechanical heart valve, DOACs are recommended. However, if we go back to what I showed you earlier in the talk, we see that the language here was actually specific to rheumatic mitral stenosis. So I want to bring our authors back, our author back, Anastasia. Can you tell us if you're aware why there might have been in these different sections a difference in the language? Then after that, I'd like to have Renato really talk to us about what do we really know about mitral stenosis and DOACs.
Yeah, kind of to one of my points earlier, I think the authors really wanted to use the evidence, the primary literature, to drive the recommendations in the synopsis. So looking at it, I'm not sure, other than just coming directly from the reference studies, that I can explain why the language is slightly different. There are a lot of recommendations to manage in this very large guideline, but we did talk a lot about getting rid of the non-valvular AF recommendation, or deleting that language from all guidelines. And I think that's where you see some of these other terms start to be put in the direct recommendations rather than non-valvular AF.
Yeah, and that was one of the things that again, I removed a slide that talked about grades of recommendation for time, but one of the things I had on there was obsolete terms, and an important one being valvular or non-valvular AFib. Lone AFib was another one that's considered obsolete.
Chronic AFib, one of my least
chronic
favorites.
AFib was the other one. Thank you. Yeah. So those terms are obsolete and were considered to be removed. Thank you for that guidance, Renato. Break it down for us. The difference between rheumatic and non-rheumatic mitral stenosis, and what do we really know about preference for an anticoagulant agent?
Yeah, that's an interesting topic, Arthur, because again, when we see a patient, that basically based on clinical history, based on some demographics, and particularly based on the echo findings, you can pretty much differentiate the rheumatic mitral stenosis from other etiologies. In a degenerative mitral stenosis, or in a patient that just got older, or in patients who use drugs, or in patients who had radiation for cancer. Those are congenital heart disease. Those are other causes of mitral stenosis. So based on the clinical history, based on the finding on the echo, the anatomical findings, you can pretty much differentiate the etiology. But the question is that those terms that you said, moderate to severe or rheumatic, moderate to severe, they have been using interchangeably in clinical practice. And what happened is that when we first designed the NOAC trials, we look at the older trials, the warfarin placebo-controlled trials in the late 80s, early 90s, and those patients basically with mitral stenosis, moderate to severe, most of that due to rheumatic disease, because the majority are from rheumatic disease, they were excluded from those trials. So basically, we didn't know that if we could use the NOACs or not. It's not that the NOACs didn't work, we just did not know. But luckily, in the last 2 years, we have the Invictus trial, almost 5,000 patients, really comparing rivaroxaban versus warfarin for patients with clearly rheumatic heart disease, rheumatic mitral stenosis. So there were echo criteria, there were clinical criteria. We can see that the mean age was close to 50, 55 years of age. Most women, classic, the rheumatic valve epidemiology. So the rheumatic mitral stenosis epidemiology. And surprisingly, Arthur, I was never expecting that results, but warfarin did much better. I had actually the pleasure to discuss the main results when it was presented at the ESC meeting a few years ago. And I said that nobody could ever imagine that warfarin actually was associated with better outcomes, including less death, including lower mortality compared to rivaroxaban. And I finished my presentation at that time saying, that's why we need and we do randomized trials. Because if we would have to guess, everyone, including me, we would have guessed that rivaroxaban would have beat warfarin in mitral stenosis due to rheumatic disease. And that was not the case. There was a clear separation of curves after 18 months, warfarin doing better, warfarin reducing stroke, and warfarin even reducing mortality, cardiovascular mortality. So again, that's the bottom line, that today, when we talk about rheumatic or mitral stenosis, moderate to severe, the most common cause worldwide is rheumatic disease. And we clearly have now an indication to use warfarin in this patient population. How about other etiologies of mitral stenosis that can be moderate or severe? Well, the AFib guideline, the AFib trials that we did, we never separate out the rheumatic etiology versus the non-rheumatic etiology. We just didn't include patients with moderate to severe mitral stenosis. So basically, I would say that we almost are extrapolating the Invictus findings to any mitral, moderate to severe mitral stenosis, particularly for the non-rheumatic etiology because of lack of data. We just don't have the trial. So
just, real quick, if I like to apply the "what if it was my mama" rule, right? So if my mother had moderate to severe, living in America, moderate to severe mitral stenosis, not rheumatic in nature, do I take as strong a stance on warfarin based on Invictus as I would were she with rheumatic disease somewhere in South America, let's say?
Yeah, I think that's the question that I said. We just don't have the hard data. We just don't have the good data in this particular case that you described. So for me, I will not take it as an Invictus patient because this was clearly not an Invictus patient. And on the other hand, if this patient is older with a lot of comorbidities, with tremendous risk of bleeding, particularly intracranial hemorrhage, in the light of all the data that we know about NOACs, and in the light of the safety of the NOACs, particularly in the very elderly comorbidities, etc., and in the lack of any trials specifically addressing this population, since they are not rheumatic in etiology, I would then discuss all these issues with the patients, and likely I would use a NOAC despite not having the strongest evidence to do so.
So shared decision-making comes back to shared decision-making. I feel the exact same way. Excellent. Thank you so much for that discussion. Got a few minutes left. I want to cover a couple of quick topics. I just wanted to point out that for all the rights and purposes from an antithrombotic standpoint, atrial fibrillation is treated the same. A flutter is treated the same as atrial fibrillation. The one difference that I might highlight slightly here is that in general, if a patient, and I didn't get to cover this because of time, in patients who have successful AFib ablation, if their CHA2DS2-VASc score is still justifying therapy, they continue therapy. Even if the EP doctor thinks that, AFib may never recur again, they continue anticoagulation therapy based on their CHA2DS2-VASc score. In flutter, that might be different, and it may be reasonable to attempt a trial off of anticoagulation therapy. I have that highlighted in this graphic from the guideline document. There's so much stuff that I wanted to talk about that we just didn't have time to talk about. There's a good section really on kind of transient or provoked atrial fibrillation and a set of surgical and non-surgical risk factors, hyperthyroidism, pregnancy. There's a section on liver disease and what to do about that. I really wanted to go through and talk about the importance of understanding rhythm control anticoagulation therapy. So patients undergoing cardioversion, undergoing ablation, there are details that folks in our practice and anticoagulation services really need to know and understand. I would encourage you to look at those. Surgical ablation, there's guidelines and there's some statements about that. Cardio-oncology and anticoagulation considerations, and really just much more. The guidelines are rich and we just can't cover it all in an hour. I mentioned it a moment ago, but special edition of a rapid recap is coming out really just to highlight some of the one-page document to cover some of the more important considerations with AFib. So I would definitely encourage us looking into that. And at this point, with only a couple of minutes to discuss, I apologize, we'll jump into a Q&A session. I'm going to pull down the slides. So let me just do this real quick. So much to discuss there. Couldn't cover it all. Anastasia as an author and Renato as a cardiologist and researcher. In the last few minutes, what are your thoughts that maybe we didn't get covered well enough? Anastasia, I'll let you go first.
I think there's a lot about procedural management of AFib that we didn't really dive in today. You kind of alluded to that. I think that is probably one of the biggest areas of research, that and left atrial appendage occlusion. I think we will continue to see those recommendations strengthen as more data becomes available. We really took a blank page approach to putting these together, and I think that's why I'm glad you like the bridging recommendation, but really going back to what the data tells us in these spaces. And so you see a lot of 2A and 2B recommendations. And I think that just speaks to, areas of future research and how we can continue to improve care for patients with atrial fibrillation.
Well, speaking of researchers trying to answer these questions one at a time,
Very
Renato, what are your thoughts?
Yeah, no, I think you did an amazing job, Arthur, to really summarize a very large and very comprehensive document, which is the AFib, guide, the most recent AFib guidelines. And there are so many, as we were discussing before starting this webinar, almost each topic could be a separate dedicated webinar, such as the complexity and the ongoing research on those things. But there are things that we couldn't discuss, like rhythm control versus rate control, which is also something that is evolving, the role of ablation, as you highlighted in your last slide. I like when you said the cardio-oncology consideration as well, which is increasingly important now because patients are dying, patients are getting older, therefore they're going to die either from heart attacks or cardiovascular disease or cancer. And the overlap of the two are going to happen the longer the patients live. So again, I think the main core of the guidelines aspects related to oral anticoagulation, I think they were at least briefly mentioned here or discussed. But obviously there were many issues that we could explore more as highlighted. The one thing that I really want to just highlight it is, for me, the still only gap that we have with not just DOAC, but with oral anticoagulant, which is patients on dialysis. So that's something that speaks really strong to my heart. I think we don't know even if we should use any anticoagulant in patients with dialysis. As a matter of fact, we did a survey in the US in dialysis clinics, and we basically showed that half of patients use, and half of the patients are not using anything. So half of the patients are using oral anticoagulants, half is not using any anticoagulant. So to me, we desperately need a definitive trial that, in my view, has to have 3 arms: atrial fibrillation, high chest vest, dialysis, randomized to warfarin, randomized to a DOAC, and randomized to no anticoagulant. That's, for me, the most important trial that we still need to be able to do to close the gaps or the clinical gaps around the NOACs. And the good news is that finally, I think we're going to launch this trial this year in Brazil. It's called Visionary Trial, and we're going to randomize through these 3 arms, and we hope to provide some really quality data in this field, which is really an unknown in clinical medicine, how to manage these patients.
Excellent. Looking forward to it. Andrea, I know we're coming to the end of our time. Do you have one quick comment or question? I'm sorry, folks. We didn't have time to get to the questions. There's just so much to cover.
Oh my goodness. I tried my best to get through the Q&A box the best that I could, but there were so many questions coming in. I think one last question. We have a webinar coming up next month. We're going to highlight geriatrics and that special population. Is there any comments with regard to our geriatric population and this guideline? Anything we should tee up for next month and consider?
Maybe if I could start with saying that, this is, I think these questions are originating from some of the things that were talked about in the Beers criteria, which kind of took some very strong stances, like, specific agents called out, don't use this agent, use this one. And the AC Forum actually commented, you can see a published work where we actually commented back on those guidelines just we felt there was a little bit too much line in the sand on some of that stuff. Also, as she mentioned, we'll be talking about this on an upcoming webinar, so stay tuned.
Absolutely. Well, thank you to everyone for joining us today. Thank you very much, of course, to all of our attendees. We know that an hour is a lot of time and it's valuable to you. And so thank you for joining us. I'd like to really give a special thanks to Arthur for his special speed talking and amazing way of conveying these new guidelines to all of us. Thank you, Arthur. You're amazing. Thank you also to our panelists, to Anastasia, to Renato for taking time to be with us and giving us your valuable insight as well. We can get to the next slide, please. Thank you very much, both of you. Next slide, please. Upcoming webinars. So we have 2 webinars in March, which is amazing. Our AC Forum Idea Initiative Committee is going to be hosting the first webinar on March 19th, highlighting thrombosis and antithrombotic care in the Hispanic community. So stay tuned for that. And then, as we alluded to earlier, anticoagulants in the older adults, we're going to round that out towards the end of the month. And we really hope that you'll tune in for both webinars. Next slide. Boot camp is back and we are going to be live. It's going to be amazing. We really hope that you'll join us May 17 and 18 in Nashville. Put your boots on. We're going to have an amazing faculty, lots of questions. This is a great thing, especially for folks who may be newer to anticoagulation or want a refresher on some of the basics. Register soon because spots are filling up. VESNA's coming up April 4th through 6th, and they have over 1,000 attendees. We talk about bleeding and clotting disorders. There's a lot of networking opportunities. If you're going to register, please register soon. Rates are going to go up on March 4th, and please, when you register, let them know you're associated with AC Forum. And we want to thank Johnson & Johnson for the support for this webinar. And all of our content was created independently by our webinar faculty. Thank you all for sticking with us and enjoy the rest of your day.
Thanks, guys.